Thank you very much, everyone, for taking the time to join us today. My name is Ariella Shoham. I'm the Vice President of Marketing at ADOC. I'm very, very excited to host this amazing panel of professionals in the world of radiology. We run a webinar every quarter, and this is the first time we run a panel. We have selected professionals from various facets of the radiology world, and we believe that they each have insight that would be relevant and interesting to hopefully all of you listening in today. So I will introduce them as they are on the slide. We have Dr. Thomas Kau with us, who is the head of the Institute of Radiology at the General Hospital of Villach in Austria. We have Dr. Eric Reinschert, who is the president of the European Society, the USOMI. And we have Dr. Charles Lott, who is the Global Medical Director and the Chair at Everlight Radiology. So thank you everyone for joining us. I will let you introduce yourselves as well in 1 minute, and of course hosting our panel is our CEO, Elad Wallach, and you can see we are from everywhere around the world. Elad and I are in New York, and Austria, Netherlands, and the United Kingdom. You all know how to use Zoom, I assume by now. This is a webinar. All attendees are on mute, but I will be moderating. I can take questions if you use the QA icon on your menu. If I see that I can interrupt as they speak, I may address these questions, and if not, we will have an open QA session at the end. We're hoping to run about 45 minutes and leave 15 minutes at the end for QA again if we do not sort of interrupt the speakers throughout. Unfortunately, Dr. Reinschert may have to leave us a bit earlier, but we will try and make the 45 minutes and let everyone have a chance to speak. I will now, before we start, ask each one of the attendees to introduce themselves. So maybe Dr. Kau, I'll let you say a few words about yourselves before we jump in.
So thank you for the introduction and for the invitation. My name is Thomas Kau. I'm the head of the Institute, as you said, of the Institute of Radiology at Villach General Hospital in the south of Austria. And I'm the initiator of the AICI Forum Villach, which is a forum that will, again, for a second time, be held in October this year and online, which is on artificial intelligence in clinical imaging.
Thank you. Dr. Reinschert? Wait, we can't hear you very well.
Okay,
yes,
maybe this is better?
Right. Yes, perfect.
Yes. Hi, I'm Eric Reinschert. I'm a radiologist in the ETZ hospital in Tilburg, the Netherlands, and I'm also the leader of the AI project in this hospital. I'm also the president of the European Society of Medical Imaging Informatics, as you explained. So from that position, I'm much involved in everything related to artificial intelligence in medical imaging and mainly radiology.
Thank you. And last but not least, Dr. Lott.
Hello, my name is Charles Lott. I'm an Australian radiologist, originally trained in surgery. Spent most of my middle career as an interventional radiologist, MSK and neuro. Came over to spend 6 months doing teleradiology in London, and 11 years later, I'm the medical director of a group which is now 480 radiologists, about 100 radiologists full-time equivalent, 300 referral sites, and our basis of work is emergency or urgent radiology, reporting imaging that is done during the nighttime in either Australia, New Zealand, or UK, Ireland, and we report it with people who are awake. In other words, the UK and Ireland radiologists are based in Australia and New Zealand, and the Australian New Zealand based radiologists are based somewhere in the Western Hemisphere, everywhere from Vancouver to Berlin to Cape Town. So we're a very distributed group of teleradiologists across the world, about 1.8 million cases a year. And I've got a real interest in the use of AI.
Perfect. Thank you very much. So I'm going to hand this over to Elad now. We will I want to put this on a view where, well, I guess you can each how to edit. We're not going to have slides, so I would just encourage you to position the images on the screen as you see fit, and I'll hand it over to Elad. Over to you, please.
Thank you, Ariella. So I want to open by saying that I am really excited about the panel we have here and the topic. So for coming from the AI side, I think that's looking broadly, I think that's what's exciting at this point in time. If I look at the evolution of AI over the past year or so, probably maybe few years or so, last year has been the year of the beginning of the adoption. First product getting the FDA cleared, product getting in the door, people, piloting, trying it out. And now we're starting to see in the adoption curve, starting to move from early adopters to early majority, more and more AI adoption. And I think the key question that we're asking ourselves, and I'm sure the ecosystems asks itself, is where is it going to be? Is it going to become standard of care? Is it going to be ubiquitous? And I think the panel we have here, I'm very excited about them because each is coming from a different perspective and angle about this topic of AI and how it could be used either more on the cancer imaging side or emergency side, hospitals or private group. And I think all of those can add up to a very interesting image. So I'll start with the first question, and I'll start, we'll do each question in order, and then I'll let all of the panelists answer them. To the panelists, I'm saying, as we spoke about, don't feel free to be controversial, feel free to contradict each other. I want to keep it spicy and interesting. So I'll start with the first question. And it's going to be a broad and general question. As each of you is coming from a different discipline within radiology, can you share how you see the clinical value of AI in your radiology practice today, and how does it impact patient care? So Dr. Ranchard, please.
Yes, thank you, Elad, for this introduction. And you're absolutely right. We are entering a next stage. We all know about the existence of AI applications. And now we're in a phase where everybody's looking how to choose the right application for their own environment. So everybody's looking for the right use cases, which is important. And so this is also what I'm doing in my hospital. For example, I'm active with AI projects 1 day a week. And this is both from, let's say, a research point of view as a clinical application point of view. So I am looking for applications that we could develop, or applications where we should examine and research how they are working in clinical practice. And on the other hand, I'm looking for applications that we can use to, let's say, increase and improve our services to patients and to referring physicians. To give you an example, we are a stroke center where a lot of stroke patients are being treated. So we need to have tools to facilitate the treatment of these patients, which means reducing the door to groin time to detect the thrombi in the cerebral vessels, so that we can immediately also contact the radiologist that is responsible for doing the treatment, the intervention. Also for trauma cases, for example, we are looking for tools to improve our workflow and to increase the, let's say, the accuracy by which we are evaluating trauma patients. So there are tools available for this, and now we are looking how to implement them and what is most beneficial. Even for simple examinations like chest x-rays, we are trying to evaluate this, how this can assist us in improving our accuracy and the service that we're providing. So this is really the next step, but we still have to, and this is something important, I think, gain some trust with the application in real clinical environment. And this will be the next phase. So we will have to now see how this can, let's say, improve the accuracy of our services and the way we provide these services, and we need to get confident with using them. So we are looking for the right ways to, let's say, apply these tools. I'll give you another example. I launched a tool for pulmonary embolism detection last year in the Netherlands Cancer Institute. because there's a lot of patients that are being followed up for cancer with CT, chest and abdomen. And these patients, well, there's a lot of patients being scanned and developed, and so there was some backlog, let's say, in examinations. So there was a delay for reporting these examinations, which also means that some patients had pulmonary embolisms, but these thrombi, these embolisms were not detected timely, unfortunately. So we decided to now implement this tool to detect these pulmonary emboli, even in follow-up CT scans, which are scanned in the venous phase. And this is being done already and successfully. So we don't have false negatives or false positives, I would like to say. And the tool is able to, let's say, prioritize the follow-up scans where the emboli are present. So this means that these patients are reported first, which is quite important and for the treatment of these patients. So, I mean, everybody's now looking for the right ways to implement these tools, and this is the next step, I would say.
Got it. I think that's all great points. What I would say, hearing between the lines, you said trauma, stroke, seems also in the cancer follow-up, prioritizing urgent care. And, you know, an underlying message that I hear is, yes, they all exist, but they still require a lot of evaluation, checking, seeing what works and in what way in the clinical workflow. And therefore, you actually have to you want and have to spend 1 day a week on those tools. I think that's fascinating.
I'm saying 1 day a week, but in effect, effectively, it's more than that. But it's not only about how to use these tools and to see what effect they have on the treatment, etc., and on the workflow, but it's also there's a next phase in introducing these techniques in the hospital. So because you need to involve a lot of stakeholders, it's not only radiologists. You also have to involve the referring clinicians, the ICT department. You have to connect with the clinical physicians, physicists, I mean, and so there's all kinds of people involved. So ICT, the ethical committees, etc. So now hospitals are now, let's say, organizing themselves to deal with this innovation, because you need some kind of a vision throughout the hospital for introducing this kind of applications.
Perfect. So Dr. Lott, I'm gonna give it to you now. And the question, as a reminder, was, can you share how you see the clinical value for AI in your practice?
Thank you very much. And thank you, Eric. The clinical value for us as a group is the use of something as a tool to make the outcome better, or the workflow better, or the prioritization better. The main one is to increase the quality of reporting. So, I mean, one of the questions at this meeting is it now the standard of care? I don't think AI is at the standard of care yet, but it is getting that way. The reason being is that it is currently a tool to assist the radiologists, and it'll assist the radiologists increasingly in those cases where they are where there is a pathology, second pathology that is missed, in other words, failure to perceive, where it is a very borderline case and quite missable. One clot out in the lung periphery, it will be missed even by the best people. And if somebody has a tool which says, by the way, look here, you actually will increase the quality of care to the patient. The other way of looking at the tool is workflow. We looked at doing our own, because we shift images all around the world all the time, we have a very good IT department, and we looked at doing some work for ourselves, and rapidly discovered that it is not in the skill set, particularly because you actually need really good test case, development case data that has the answer. And as you know, that even in your institutions, say Thomas and Eric in their own institutions have trouble getting feedback. You try and get feedback from 300 sites where you're a third party, you're not going to get that kind of good data. So 2.5 years ago, we had an intense focus. We have an AI advisory board, and we basically said to everybody in the business, we are not going to say anything about AI at all. It was the Wild West. It wasn't there. It was full of hype. The hype is now rapidly settling. There's a whole lot of people running out of cash and doing whatever they need to do with their businesses. And certain people, of which ELAD is one of the leading groups, are coming to the fore. We looked a year and a half ago and 2 years ago and a year and a half ago at all of these markets. We looked at vendor supplies. We looked at the marketplace, BlackRock's, all the others. And we didn't like what we saw because the implementation inside your institution is not easy. So when you have a tool, the tool's got to be easy, it's got to work. And the current relationship we have with ADOC is we had to make a tool that would work across the world. In other words, it's not just the from the scanner into the engine looks and sends it back into workflow of one institution or one enterprise. We're looking at an enterprise across the world and working out how you can do that in a timely fashion. So there's the complexity of how to make it look easy is one of the current issues in our world. And applause to ADOC in that they have spent a lot of time and resource working out how to do that. I'm sure it's useful for ADOC, but it is incredibly useful for us because otherwise it wouldn't be usable. If I got a notification 20 minutes after I reported a case, that's like peer review next day. It's not like actually a tool at the coalface. So coming back to the types of tools that look for PE, excellent. I think, Eric, your comment, things that look for PE in oncology scanning, I would like people to actually use some form of either arterial and portal scan or a biphasic scan, but straight portal lung doesn't really get up to enough to be good at PE, and any assistance will be greatly received and also point you to say, look here, and you'll make a much better decision. In our world, emergency radiology, I would love somebody to have a tool that reliably tells me rib fractures in a polytrauma case. But at the moment, we're looking at intracranial hemorrhage, and the tools are very good at assisting us. We're looking at pulmonary embolus, and we're looking at pulmonary embolus in the incidental, and we're going to evolve into greater and greater fluids. So to me, the question is it standard of care now? No. Will it become standard of care? Yes. What will be the standard of care? And the standard of care is the one that provides a utility benefit to the patient and reduces the error rate of a radiologist. In the future, we may lose our entire jobs to AI, but that, I think, is certainly not in short term, and it is probably not really medium term either. So current standard of care, it's a tool to assist. That's my view. Thank you very much. Yeah.
Oh, thank you, Dr. Lott. I want to just add one small point on that, on the thing you mentioned around the workflow. I agree. I think when thinking about standard of care, it's how do you also integrate into the current standard of care, and then you have multiple levels of that. How do you integrate clinically and make a clinical workflow out of the integration of human and AI? How do you make an IT workflow and all of that? And making those workflow tick, I think, is at least one of the biggest challenges we had to face when implementing, especially at the big groups such as yours. Dr. Cow, so going to you now. So how about yourself? How do you see the clinical value for AI in your practice?
So we've heard about the acute setting, and this is something, since I'm representing a public general hospital, which I'm especially interested in, of course. May it be the acute intracranial hemorrhage, or may it be stroke, maybe fracture, polytrauma, all that. This is something very important for two reasons. You have to be fast, and you're confronted with a huge amount of images. That's the second thing. So we are probably as radiologists quite good in detecting something, but it's more and more a difficult situation to have a look at such a large amount of images. So this is something where AI is certainly a good tool to have. Second thing is there is tedious work in our daily practice. So not everything that we do is being done with great comfort, or do we like very much. So there are some aspects of our work that we would easily give away to some machine, and there's no doubt that also my co-workers would argue like I do now. The third aspect I would want to come to is the screening situation. So at the moment we are trying out pulmonary embolism, intracranial hemorrhage, and rib fractures, which is quite good to pilot, let's say. But next thing I would be interested in is a screening situation like with breast cancer screening, where we have double reporting. And I know there is first literature, quite highly published, on double reporting with breast cancer. So the first report is being done by a human radiologist, the second by a machine. And this is certainly a situation I'm quite interested in. I'm really curious how this is going to develop, because this is not a vice versa. This is something that could probably also decrease our workload, and at the same moment increase our accuracy. And then it's too obvious. It's all too obvious that at the moment we are trying out algorithms on frequent pathology. But to be honest, there's also rare disease, which is certainly something that may be developed within the next few years rather than months. But there are rare diseases where most of us are not really very good at, because just because of the fact that it is rare, and not all of us are specialists in every aspect of radiology. So if there is, for example, an algorithm that helps me with diagnosis of metabolic brain disease, I think at least most of us would agree that this would be something good to have. But personally, I think this will take quite a time to get the first algorithms in this aspect of radiology. And then, of course, there is this word called radiomics or radiogenomics. If we integrate imaging patterns with genetics, and this is certainly going to even go a step beyond, because it will probably detect pathology that at the moment we are not even able to give a name to. So this is certainly something for the future, hopefully the nearer future, that we get something like that into our practice. Your second question was standard of care. So I think very important things have been said about that. I shouldn't repeat that. For me, there are probably four aspects on the way to standard of care, and probably we are in the middle of the way. But first thing is integration. So how can we integrate AI into our workflow? So choosing the vendor that gives us AI algorithms has multiple facets, but one of those is how would you want to integrate, let's call it a widget or whatever gives you the red flag. How are you going to integrate it into your PACS environment, into your workflow environment? Is it going to raise the hand by itself, or do you have to click something to get an idea or get the report? And also the question is, how would it project into a report, probably, if it does. So this is integration. The second is security. In the general hospital, you have to ask the question, are you going to be served on premise, or will it be a cloud solution? At the moment, it's rather on premise than via the cloud, but this is certainly a very basic legal question, and therefore security question. Third aspect out of four is, let's call it evidence, or how accurate will your AI solution be? So you are you will get the numbers by the vendor. On the other hand, of course, we are used to do evidence-based medicine. So any sort of evidence, no matter how difficult it would be to get it, but any sort of evidence or proof of your accuracy, whatever the metrics will be, are going to enhance the reliability out of the view of the practitioner, the radiologist, for example. And the fourth aspect is communication. So it is, like we have heard before, the communication between all stakeholders, the technicians, the clinical doctors, the researchers, and obviously also the vendors and politicians in lead of any decision. They have to communicate. I think a lot has been done to bring it down to the ground, and now we have to see how to integrate it into our work, into our daily work.
Thank you, Dr. Kao. And yes, you addressed like the next question already, but that's good. I'm going to hand it back to Elad to keep the panel running. Thank you.
So I do wanna take just a couple of minutes as long as we have Dr. Ranchart. So I want to ask about the, let's say, elephant in the room, which is the COVID-19. And how do you think it will impact the adoption of AI, short and long term? And whenever, I know you have clinical workflow you need to drop off to, so whenever you need to go, feel free.
Yes, okay, thank you, Elad. Yes, the COVID-19 crisis is a very interesting one, as a matter of fact, from the AI point of view, because I think for me it was an excellent opportunity to set up an initiative for doing research around the, let's say, development of an AI algorithm for analyzing CT scans of the chest and making an accurate diagnosis of COVID-19, and also to assess the amount of lung volume affected. So from that point of view, and this is, I saw, well, in this crisis period, I saw that there were a lot of possibilities to get people motivated to get engaged in this kind of development. So which was kind of an opportunity, because you have to do everything within short notice. You have to convince the IT department. You have to convince your colleagues. So you have to, let's say, talk to all stakeholders and motivate them to do something within short time, and maybe even, let's say, pro bono, to help solving a problem. And this actually was a good moment to launch this initiative, because I was amazed, and I'm still amazed to see how much people we were able to engage in this project and to become active. So this is a still ongoing initiative. So we are still collecting data. We have to annotate data, and that's maybe more important. By doing this, we, as radiologists, we were able to become engaged more actively ourselves, because somebody needs to be found to annotate the images. And so we were able to develop, together with the industry, to create a platform where we could efficiently annotate all the images, so that we can learn how to do this. And this is kind of exceptional. And actually a lot of colleagues working with us, they become enthusiasts. They say, oh, this is nice, we should do this more. So now the awareness is being created among all the participating hospitals and colleagues that this is actually not as difficult as it looks like, and that we can play an important role in this, and that we can together develop something, not only on ourselves, but also with the other people, with the industry, with the all the IT department, etc. We can do something together. We can work. We can develop a tool that we need, and of which we think it will be effective, and which is even more interesting, that we will be able to evaluate the tool in our own environment. So yes, I think I can talk a lot more about this project, but the main thing for me is that it was an excellent time to introduce it and to make, let's say, the possibilities of AI more visible in the clinical environment and also among colleagues. And yes, I am very, let's say, hopeful that this will result in a nice in a nice product, and then we will learn a lot more about how to use and implement these tools and how they are being developed.
And I think you all talked about the, I would say, level of communication, making everybody aware of AI. And it seems like what you're saying is that because of this call to arms around COVID and the fact that everybody is involved with this AI, specifically this AI project, but everybody's involved, it kind of creates this framework that everybody starts to become aware, enthusiastic, and you think it will drive adoption then in the near future, I assume.
Yes, yes, it is a good way to, let's say, motivate people about the possibilities of these new tools, and actually to take away all the fear of become engaged with developing this kind of tools or introducing these tools in the clinical environment. So, yeah. I mean, okay, it's kind of a disruptive moment. COVID crisis is disruptive for all of us, but also for the introduction of AI in the clinical environment. That's my perception.
Great points. Great point. Thank you, Dr. Ranchard. Dr. Lott, what do you think about the COVID impact? Again, short and long-term impact on adoption of AI.
Depends if you actually have a COVID-specific tool, and I'm sure that it will be developed, but it'll probably be developed as we either go before the second phase or there'll be no second phase. It'll be interesting to see whether it becomes a small subset of unusual pneumonia patterns, atypical pneumonias, or whether it still stays as the big impact affecting the world so much. The fact that the UK, France, Italy, Spain, Portugal, US, and now maybe Brazil have had such an incredible impact. And then my home country of Australia, which has a direct link with China in travel, and there is a Chinese immigrant and Chinese transient population, seem to have actually scored a lucky golden ticket and missed out on a huge impact. So it's had a financial impact, but not in a medical way. So, I mean, COVID, I think, will just be another part of the development of lung AI, which will give you yet another pattern of atypical pneumonias. I mean, SARS, MERS, now COVID-19, all into the atypical pneumonias, sick people, small number with massive immune response and sudden death or prolonged bad outcomes. So I think it will evolve into a subset of atypical pneumonia AI identification. You know, we still have, if you take the Indian subcontinent, if you are using an AI tool purely there, you're going to have a different subset, and you're still going to have TB and other sorts of things in your prevalence group. In I presume in Austria, Australia, and the Netherlands, TB is a real but very small incident occurrence. COVID, I think, will become one of the smaller incidents, but as an opportunity there. If we just go onto a couple of other bits that come from AI, and one of them is to do with AI adoption as standard of care will depend on the cost. If it's unbelievably cheap, which of course Elad will agree with, that's the right price, unbelievably cheap, it will work very well. It will be easy to adopt. If it's incredibly expensive, it won't. So there's a right price for it. Another one is user interface, and I think you actually mentioned it. For Thomas, user interface with a screening, user interface with a polytrauma case, stroke cases, they all have to occur quickly, and they've got to alert you, but not in a way that distracts you. So user interface, how to make the tool tell you what you need to know, make you be able to check what you need to know. We've evolved with Elad and the guys at ADOC, evolved it into the tool widget on our desk, on our interface in our proprietary risk system, such that it will tell us that a case has been looked at, it tells us that a case has been reviewed, and it'll tell us a case that has had a...
Dr. I think we lost Dr. Lott, so Dr. Cow, maybe we'll continue with you until Dr. Lott re-engages. Please.
I'm going to step in with the same question, right?
Exactly.
So regarding the COVID-19 pandemic, I mean, there are a few aspects. So first aspect is, first, I'm not inventing any algorithm like Dr. Ranjit, but still I'm curious how good that will be. Because it's a very good topic for having a pathology that is obviously typical but not specific. Because the first case we thought would be COVID-19 pneumonia was in fact influenza in our hospital. So anyway, this is one topic. Second is I think we can believe that. The acceleration of digitalization is also a tailwind for all sorts of software and also AI algorithms, I think. So I think that people are a little bit more alert about what is being offered in the field of software. Third thing is as I said, I'm the initiator of this AICI forum, AICI forum, which will be held in October 2020, but online, obviously, because it's too risky even though we have just a few cases here in my part of the world, but it's probably too risky in a financial way to get all the people there if they can travel anyway. So we're going to do that online. This is also something thanks to the COVID pandemic. And there's a fourth point I'd like to address very shortly, and this is fairness. So Mr. Kokelberg, I have to read the name because it's a philosopher from Vienna. He said something like, some are less digitalized, I read it, some are less digitalized and more vulnerable. So just like with vaccination, also AI algorithms, they are provided to some parts of the world more easily, and it's a matter of money, of course, also. But I think this we should learn also from this pandemic that fairness should be part of the game somehow.
Yeah, that's a great point. One of the questions regarding the COVID pandemic is there are two very high-level trends that people speak about. One of them is that because of the lack of elective care, some hospitals are losing revenue and are thus less prone to adopt new technologies. Others say that in contrast, this is the age of digitalization. This is the age to invest in new technologies, and AI has been shown to be helpful during this pandemic. Dr. Kav, do you have, do you have thoughts on, kind of the two mega trends battling each other for the future of AI, let's say?
I do. I mean, I do somehow. first, of course, since it's a matter of money, it will be also a question how much money is going to be spent within the next few months. Okay, so budgets are probably not going to rise. Probably this is an aspect that will affect also the adoption of AI in clinical practice in, let's say, a public hospital. Of course, that's the first thing. The other thing is, I mean, this topic is not something that has popped up now. It is such a huge topic, such an important topic. So this is a trend, and probably this trend could be deviated somehow. But we can and we should not take the break and wait for another 2 years to talk again about it. So developers are developing, and those of us who are interested in piloting that in a clinical practice like us, they are doing that. And I think, I mean, as we heard, the fear has diminished to some extent. I would say to a great extent, the fear has diminished. And now it's more a question of how to convince the clinical radiologist that this is a good thing to have. And obviously let's say the accuracy and how it projects into your workflow. These are the two things that you have to face when you're trying to convince the clinical radiologist. And this has been with all tools we are using now. And to be honest, there always have been some of us that have probably had the idea that post-processing is probably not necessary. Having 3D images is probably not necessary. Having multiplanar reformats is probably not necessary. But it is. I mean, it wasn't 20 years ago probably, but there is something about it. It's probably not the most important, but we are trying to get better and better. Let's say from 93% to 96 or 97%. This is a difference, but it is a small delta, and we have to convince ourselves to use this small delta.
Terrific. Dr. Lott, anything you want to say, I would say, to finish your last points, or should we go to the Q&A section?
I'd just like to apologize. I had a good old-fashioned power failure. I'm self-isolating because of COVID, away from my reporting hub here in Cornwall in the UK, and I'm down in a small secluded valley in the studio of an artist, which is why I have those pictures behind me. And she says occasionally they just have a power failure like we just had. When I was talking, I just was talking about the user interface and the way the radiologists behave with the AI tool. And that actually is a human behavior interface piece of research that hasn't been done in the way I know. And it is an opportunity, it's an opportunity for research, you know, for maybe the big American groups to do some research, but I think also in Europe there's a distinct areas of expertise where you could actually look at that in a quite detailed way to see what will happen when you put a tool in front of someone. What will be the outcome? Because remember, the train drivers, high-speed train drivers, pilots, whatever. If you automate too much, you end up with increased risk to the passenger. If you automate too much in AI radiology, what will be the outcome? You know, for example, the ECG machine in I think it was the Brigham Hospital, Brigham and Women's. For 6 months, the automated report of the ECG machine was incorrect, and no one noticed. Either they weren't reading the report, or they were trusting it with its normal reports when it may not be. So there's more to the use of AI than simply, you know, getting the answer and getting your machine learning up and going and managing to not burn through all of your startup cash. I think it's a new world, and it's a tool. The other risk is who actually does the AI. Is it going to be stuck inside one of the major vendors' CT scanners and you get it for free, therefore no one can compete? Is it going to be provided by the PACS people? You know, We have big PACS vendors, we have small PACS vendors, we have good and bad PACS vendors. There's a mix in there. You know, how will they work with AI to their benefit? And down at the user level, it's probably best if it's a marketplace and it's mature and has standards to it. Anyway.
All great points. Obviously, I have a lot of opinions about the, I would say, about the integration of the different vendors, but we'll keep it for another webinar. I believe because we're right at the top of the, I would say, 45 minutes. So maybe we'll open it up for Q&A from the audience. So Riela, are there any questions? I see we have,
I have
quite a lot of questions here.
Right. Actually, this came up when we were talking about standard of care, and one of the people in the audience said, do you talk about this technology to patients? Do we think this is ready to bring up from a patient-facing perspective? What are your thoughts?
In the teleradiology world, the patients are one or two steps removed from us. And so the patient equivalent for us is the referring doctor or the responsible clinician, practitioner in the institution. So no, I don't think you say to someone that you're using a specific tool. AI is not something magic or demonal, a demon. It's a tool. It's a good tool. It's a bad tool. It's up for us to make sure that the tool is useful and beneficial to the referrer and then to the patient.
Great. What do you think, Dr. Cow?
So from a legal perspective, we don't need to, because we're still as human radiologists in the lead of the report. And in fact, there are some interested patients that we are talking with about this topic, but rather does the public realize, thanks to our IKI forum, that there's something going ahead and that we are interested in such new technology. And obviously people know that radiology has become very technical, no matter how you call this software.
There are
So another question I see here from the audience, it's relevant to both, but one of the questions is what's the value of AI for potentially being used as a peer review tool, considering the fact that you have very busy practices. So A, is it helpful in that regard, and B, is it something you want to focus on as I would say, an initial value proposition for AI?
I'll answer the first bit. From day one, we have integrated peer review. Everybody must do it. All radiologists must do it every reporting session. And then we have ways of dealing with the outcomes. With the current tool, we have, the radiologist not part of the testing system, natural speech language will say that they didn't get the answer of a pulmonary embolus wasn't in the report. So that alerts to us. So it is actually forming part of our peer review anyway, which is to patient benefit. But from the point of view of pure peer review, currently and for quite some time, AI tools will answer a specific question, not a general question. For example, if you believe you should be reporting adrenal adenomas that are found incidentally, and there's a debate about that, but if you believe you should be reporting secondary findings, unexpected findings, and so forth, human peer review is probably still the generalist. Yeah, we are the general device currently, and will stay that way for quite some time. So I would say peer review should be done by peers. As a tool in peer review, ask a specific question about pulmonary embolus, yes, run it through. But in the ADOC system, everything's already run through. Everything that the machine says is a CT pulmonary angiogram or a contrast chest now will have gone through that. And so it is a peer review tool in that way, but it's specific question peer review. It's not a general one. So it's not peer.
That's a great point. Dr. Cow, anything to add on that?
Yeah, I completely agree with what has been said now. And I'd like to add, probably, as I mentioned before, the screening situation with breast cancer. I mean, mammography is something with quite a few imaging patterns that have to be recognized, and probably a screening situation where you have one human reader and one machine, and then the human decider, if there is controversy, would be something where the human is still in the lead. But other than that, you are still using the potential of AI. But as we have heard before, in most clinical scenarios, you have a diverse spectrum of possible patterns and pathologies, and there is not a single solution that includes all of that right now.
Yeah. Moving on to another question, which I think I see repeating by a few attendees from the audience. It's a very practical question. When starting an AI project in your institution, how do you start? Do you start with a research project? Do you include the vendors, or do you go straight for implementation and trial? And how does this whole collaboration is started in a good way?
Maybe I'll answer the start.
Please.
Decide what your institution's for. If you're Johns Hopkins, you'll have wonderful research projects lying around all over the place. If you're Grossharden in Munich, you've got lots of stuff to do. If you're a clinical reporting service, you're not going to do the research, you're going to do the evaluation as a tool. And the evaluation of a tool, if you're going to start, ask what you want it to do, ask them what the tools can do, and then say, show me that the tools will work in our institution, in our world, because we send terabytes or gigabytes of data across the world all the time. You've got problems of latency and implementation. In other places, you've got human issues, workflow issues. So to me, how do you start an AI project? The answer is ask a question. How do we prove that it is of economic and clinical value sufficient that the board of the institution or the organization will be willing to part with the cash to put it in?
Yeah.
The answer is they're always reluctant, but that doesn't stop me from asking.
I think that's a great point. It's about, I want to reiterate what you said earlier. AI is really good at answering a specific question. That's more on the clinical side. And then you, I would say, on the more from a broader perspective as an institution, you want to ask a similar question. What pain point am I solving here? And what are the benefits, both clinical and financial? And can I justify the whole project? Dr. Cow? Sorry, Dr. Olaf, you want to add anything?
Yeah, again, I fully agree. And probably I would like to add that from the perspective of a public hospital, I mean, there is first you have to first choose an AI vendor that is in a position to help you with all steps of piloting something like that, because probably a lot of institutions do not have the people to cope with all aspects of that. That's the first thing. I mean, that's the same with a lot of solutions, but this is something new, obviously, and we are probably beginners with that. And the second thing is, I mean, you probably, like we've heard, you have to choose something that you are prepared for. And at the moment, it should be first pathology that is quite frequent. And second, something that affects all of your co-workers. Because if you try it out with some solution that affects probably 1 or 2 out of your team, and this may be rather rare disease, then that's not something that then you don't roll it out broadly. If you want to roll it out broadly, if you want to gain experience with your whole team so that they also interchange their ideas, you have to choose something like pulmonary embolism or rib fractures that is quite obvious and quite frequent.
And that leads to the one, if somebody wants to sell you a tool to look for cirrhosis, if he wants to do liver scoring, if you want to do coronary artery calcification, all of those things have their uses. But in our world, bleed in the brain and pulmonary embolus are obvious questions that have utility. Whereas somebody says, I've got a great tool for doing crush fractures, you're going, well, I'm actually not bad at crush fractures. They're there or they're not. And it doesn't actually change the outcome for the patient unless there is some intervention to protect them from getting crush fractures. And there's a whole world to do with that. So it is important, but it is not an important question from the point of utility. I think, Thomas, you hit it on the head, and you added the bit about screening, which is something we do not get involved in because I don't think in our distributed teleworld that works properly.
Yeah, great points.
We have three minutes, so I'll just let you each say just any topic that may not have been addressed before we say goodbye. There were great questions, and we'll try and address them offline. Just in the interest of time, I want to stay within the hour. So, any parting thoughts, Dr. Cow, Dr. Lott?
Thomas.
From my point, so be sure not to miss the AICI forum online on the 30th and 31st of October this year.
Absolutely. Dr. Lott?
I think this is an exciting time to get involved in AI or AI as AI tools assistance. Workflow, clinical, the stuff is there, it's starting to mature, it's only going to get better, the data sets have to get better, and the utility will get better, and it's better for the patients. So it's going to be the standard of care. It is not now, but the Wild West phase is not fully over. The next phase will be the salesmen in smart suits, and you've got to work out who's got something to sell and who's got something that is smoke and mirrors. So it is still a problematic world. I think the willingness of vendors to trial with you and withdraw if you don't like it will tell you who the ones you should be joining up with. Anyone who wants you to sign in black ink before you've even seen it in use, you've got to work out whether that's the right way to go.
Thank you very much.
The Wild West analogy.
Any parting thoughts before we say goodbye to everyone?
No, I just love the Wild West analogy, the good, the bad, and the ugly of AI.
That's our next blog post. Thank you so much, Dr. Lott, Dr. Cow, and Dr. Einstein, who had to leave us. And thank you to our listeners for staying with us for this hour. We will be sending a recording to everyone as well with some of the main takeaways. I really appreciate it. Thank you so much for joining us. Have a great rest of your day wherever you are.
Thank you very much for having us.
Everybody.
Yeah.
Bye-bye.